stop.
Thank
Yeah,
you.
that's on choroidal nevus and choroidal melanoma. What's what?
So yeah, so before we go on to what's what, uh, it's very important that why do we need to differentiate now. Larger lesions are very easy to differentiate, though there has been a focus on diagnosing small choroidal melanomas, and the recent literature, especially in last couple of years, has shown that melanomas as small as less than 3 millimeter in largest basal dimension also metastasize, or can metastasize, and tumor metastasis correlates directly with the increasing tumor base and the thickness of the tumor, and also the tumor related mortality. So the early detection is very important. Uh, this also avoids over referral to ocular oncologist, allays patient anxiety, and overdiagnosis, or a tendency to treat these lesions with plaque brachytherapy. So let's get this. So the challenge lies between distinguishing a benign choroidal nevus from a small malignant melanoma. There's a huge list of features of melanoma, uh, and it is very difficult, to really put this into practice, especially if you have a referral practice and you see more than one patient a day. So to keep it simple, I usually follow my one of my mentors mnemonics, which is most. Uh, it is actually that simple. So let's break it down. So melanoma, let's keep it to just three features now: orange pigment lipofuscin, subretinal fluid, and thickness. So orange pigment is best seen on fundus autofluorescence. Subretinal fluid is best seen on an OSCCT, and thickness is best done on ultrasound. So I hope you can see. Yeah. So this is a classical nevus. You see that's a flat lesion. There is no orange pigment. So we are on the first O, and so this would be diagnosed as a nevus, and you could follow this patient up annually. Again, a very large lesion, more than 3 disc diameters, but there is no orange pigment. The fundus or autofluorescence is negative, so you can easily follow up these patients. Another patient, you see that these yellow dots, these are drusenoid changes which were seen on the OCT. Again, no orange pigments. You can easily follow this patient up serially annually for any change. Now compare this lesion. This is orange pigment over its surface. It's an elevated lesion, and if you were to do a fundus autofluorescence, the orange pigment really lights up on FAF, and a diagnosis of melanoma can be made. The patient then got an ASOCT, and you see that there is subretinal fluid, and in addition to the subretinal fluid, there are these dysmorphic or shaggy photoreceptors, as they are called, hence clinching the diagnosis of melanoma, and the patient would be subsequently taken up for a plaque brachytherapy. Ultrasound is very important to ascertain tumor thickness. A random cutoff of tumor thickness of more than equal to 2 millimeters is taken as an indication to treat. Thinner lesions can be followed up for change. So ultrasound findings of classical melanoma would be thickness more than 2 millimeters, moderate to low internal reflectivity. There could be a mushroom shaped picture if there is a breakthrough through the RPE. Vascularity can be ascertained if you're doing a dynamic examination. There can be choroidal extubation, and in advanced cases, there can be an extrascleral tumor extension as well. So, even if you are suspecting that it's a clear-cut nevus, a baseline documentation is mandatory in such cases. So, a good fundus photograph, and ASOCT, if fluorescein angiography is available, ideal, and an ultrasound should also be done. Uh, strong. If these features match, then there is a strongly suggestive of choroidal melanoma. A short duration, growth in short duration, or a previously normal fundus photo, if available, also points toward a suspicious lesion. So if there is no suspicious feature, then it's a definite nevus. So O is negative, S is negative, and tumor thickness is less than 2 millimeters. The patient can be easily followed annually or 6 monthly, for 2 visits followed by an annual visit. If it is a suspicious nevus wherein one of the features is present, a closer follow-up is mandated, and obviously if it's a clear-cut melanoma, that needs to be treated. Thank you so much.
Thank you so much, Dr. Puneet. Ma'am, you have.
Yeah, that was a very interesting talk, and I always keep wondering, where they mention these tumor heights. It is like which stage of the tempora in the history of the lesion you catch it. So suppose it's a very early melanoma, it can be less than 2 mm. Also, I always wonder about these things and about the early stage retinoblastoma. It's all how high your index of suspicion and whether the patient is caught by some ophthalmologist in a stage when it's very early. So those are the lesions which are very, very tricky even for an expert in the thing. And I mean, what we read, like we teach them more than 2 mm. I mean, the tumor has to start at 0.5, then go to 1, then come to 1.5 and 2. So I always have a little bit of a, I mean, I look at it a little bit differently. Like, is it to start with 2? It cannot be, na? So always feel, I mean, maybe it is detected or referred or becomes symptomatic when it acquires that size. That is what I keep feeling, even about retinoblastomas, especially the A, B, and the early ones. It is impossible to catch them unless you do a widespread screening. It's just impossible because when they come to us, they're in D, E most of the time. They become symptomatic. So always wondered that thing about this, and that's why I brought out this in. I mean, amongst all these super specialists, I should say. So just wanted your take on that.
Ma'am, I totally agree. Like any tumor has an evolution, right? Yeah, it starts from a small tumor to a bigger tumor. So when probably Puneet mentions about 2 millimeters, one of the risk factors. So this is basically the features where you have a lot of confusion. In fact, it doesn't happen in India because we don't see too many nevus, especially in the Caucasian population where they have so many nevus, appearing in the choroid, and most of the time they are seen by optometrists, not even by ophthalmologists. So that is why there was a reason of coming up with certain features which can differentiate between nevus and melanoma. It doesn't actually imply the fact that, yeah, anything which is 2 millimeters is melanoma. It is an evolution, as but there are other features also, like orange pigment, presence of a drusen, which kind of differentiates it. Subretinal fluid is a good hallmark because whenever there is a tumor proliferation, it starts exudating. There will be fluid which will be formed. So that is like a clear cut thing. Yeah, yeah, yeah.
Absolutely, no argument with those other features, only about the size. And I think because of that, follow up is the cornerstone of managing, close follow up, maybe 2 monthly, 3 monthly, or SOS is the main thing.
Ma'am, in the same line, I would like to mention something like there is something called a diffuse melanoma, where there is where the thickness is hardly 2 millimeters, but then the basal diameter is so much, there will be diffuse thickening of the choroid. So there is definitely here and there, not everything is like the foolproof evidence of having a melanoma. So we should also keep in mind, especially in patients with nevus of aorta, diffuse choroidal melanocytosis, these patients can also turn into a melanoma, and they are in have to be followed up looking for other features. Yeah.
Yes, ocular melanocytosis. I mean, if it's very, very diffuse and it is very difficult to say that it's benign unless you take biopsies from many places because exuberant growth is there sometimes and of short duration. The exuberance is of short duration. The melanocytosis might have existed for years together, but suddenly gets exuberant. So yes, I think there is a spectrum there. I think there is a spectrum.
So when we talk about diffuse melanocytosis in nevus of aorta, if there is subretinal fluid, even a little in and around the lesion, it's probably getting evolved
Evolved
into a melanoma. Yeah. So these are certain things that gives us clue.
Absolutely,
I
very
think
good.
the thing that I was trying to highlight was that uh, in North India there is a trend, so under investigate. Some people over investigate and some people under investigate. To determine the evolution, you have to have a baseline. So we I come across a lot of people who say, did you get a baseline OCT done that time when you first saw the patient? तो nervous लग रहा था, नहीं कराया. So in order to determine those, you have to have checkpoints or like milestones where you have serial pictures. Then only you can tell. So a lot of these patients, they do evolve. Nevi do evolve into melanoma, which is why it is very important to have a baseline documentation. However, innocuous the lesion might appear when it
Yeah,
comes to these
no
melanotic
argument
lesions.
with that. Baseline and follow up, I think, is the cornerstone to catch things early and prevent lot of morbidity.
As Puneet rightly mentioned, the clinical features are the crux of certain diagnosis, but ma'am mentioned about ASOCT in ocular surface. Similarly, in intraocular tumors, like sometimes a very subtle SRF is never identified clinically, you know, even best of the best ocular oncologists. But the posterior segment OCT really helps in, identifying a very subtle subretinal fluid around, and that is a big clue. So I think with these diagnostic modalities where we have scientifically and technologically advanced, it is definitely a good armamentarium. Yeah, thank you.
Thank you so much.